Hey, hello everyone. Welcome to our I'd like to welcome all the participants for this data access event. And before we begin, I would like to do some territorial acknowledgement. That's okay. The Lekwungen speaking peoples on whose territory the university stands, whose historical relationship with the land continues to this day. Before we begin, I would like to provide a general overview of the Institute on Aging and Lifelong Health. Institute was created in 1992 and is UVic's leading intensive health research community. The Institute is committed to promoting and conducting rigorous basic and applied research to improve quality of life. The Institute also encourages and supports and promotes multidisciplinary collaborative research projects. And the Institute currently has over 100 faculty, postdoctoral students, community and external affiliates who work collaboratively in areas of lifespan health research. The Institute has 5 research clusters: brain health, digital health, health behaviors and interventions, population health, and health services and systems. This relations. So just to give you an overview of the day and how it will work. The event recorded and will be available on the Institute's YouTube channel by November 15th. Over the course of the day, the event will explore 3 major themes: the systems issues related to collecting, storing, and managing health data, data platforms containing health data from various sources, and specific data sets. There will be 6 sessions total. Each session, except for the last one, will be approximately 55 minutes long, and each session will consist of short presentations followed by a Q&A period. People will have opportunity for a short break after each session, and people can sign in and out as they choose using the same Zoom link that was sent from the invitation. At the end of the day, we will send out a short post-event survey, and we'll greatly appreciate if participants could take a few minutes to complete and send it back. And also, for the opening, I would like to our first session, which is the Health Data Research Network Canada and the Pan-Canadian Health Data Strategy by Dr. Kim McGrail. And I would like to do a bit of brief bio introduction before we introduce the speaker. Dr. Kim McGrail, who is a professor in the School of Nursing of Population School of, she's a professor in the School of Population and Public Health and the Center for Health Services and Policy Research at UBC. She's also the Scientific Director of Population Data BC and Health Data Research Network Canada. Her research interests include quantitative policy evaluation and all aspects of population data science. She conducts research in collaboration with patients and the public, as well as with policy and decision makers, including the BC Ministry of Health, BC's health authorities, Canada Health Infoway, the Institute for Health System Transformation and Sustainability, and the Canadian Institute for Health Information. Dr. McGrail is also an interim editor-in-chief of the International Journal of Population Data Science. She was the 2009-10 Commonwealth Fund Harkness Associate in Healthcare Policy and Practice, the 2016 of the Renzi Prize for Excellence in Teaching, and the 2017 recipient of the UBC Award for Excellence Applied Research. In 2019-20, she participated as a member of the Canadian Institute for Advanced Research Task Force on AI for Health, and from 2020 and 22, participated as a member of the Expert Advisory Group for the Pan-Canadian Health Data Strategy. She's currently a member of the Global Partnership for AI, which includes members from 15 countries who are nominated by the national government. She holds a PhD in healthcare and epidemiology from the University of British Columbia and a master's in public health from the University of Michigan. I would like to really welcome McGrail, and thank you for this opening session.
Thank you so much. The bio is a bit exhausting for everybody, I'm sure. So I really appreciate the invitation to be with you today. And before I get underway, I'll just say I was experiencing a little bit of jitteriness in the connection while Jan was introducing me. So I'm just going to ask anybody, just raise your hand. If I'm cutting in and out, I'll switch over and stream from my phone on the Zoom call if there's a problem with the Wi-Fi where I am. So this is a topic that or a couple topics that I could probably talk about for several hours. But I'm very committed to making sure that there's time for questions. So I'm going to just pull up some slides here and just like make sure that you can see those okay. Oops. Yeah, okay, good. So I will keep an eye on the time. I am going to leave time for questions. So please do keep track of the questions you want to ask. I hope that we have some good discussion when I'm through these bits that I want to cover. So for today, I am actually, most of the time I do my work from the traditional ancestral unceded territory of the Squamish, Tsleil-Waututh, and Musqueam people. UBC itself is situated on Musqueam land. And I think it's probably important to understand my perspective when approaching the topics we're going to be talking about today. I am an immigrant to Canada from the United States. I'm originally from Michigan, the traditional land of the Potawatomi people. I am really committed to ideas and principles of equity in healthcare use, healthcare financing, and that sort of thing. And that's been a big focus of my research. And you probably hear strains of that in some of the way I talk about the issues that we're going to be talking about today. I don't have any conflicts to declare for the presentation I'm going to be making. I have been part of the conversations that have surrounded a lot of these things, but I don't think that inherently creates conflict. And what I'm going to do as an outline is I'm actually going to start from the Pan-Canadian Health Data Strategy and then work our way inward from there. And I hope that this really sets up the rest of the day in a sense, because you'll see some ties to many of the other speakers and the other topics that you're going to hear about during the course of the whole of this conference. From the Pan-Canadian Health Data Strategy, I'm going to focus a bit on the Health Data Charter, and then I'm going to really dive into Health Data Research Network Canada and multi-regional research, the kinds of things we're trying to support, and talk a little bit about next steps. Okay, so starting with the Pan-Canadian Health Data Strategy and the Charter. So what you're going to see popping up on the screen here are all headlines about data and health data at the start of the pandemic. And I never would have anticipated that epidemiology and health data, both of which I have background training in, would have become such common parlance. I mean, it used to be that people had no idea what epidemiology was, and now I have a coffee mug given to me by a friend that says, make epidemiology boring again. And I wholly subscribe to that message. So the idea here, though, is that the pandemic really brought to the forefront this idea that there was a problem with our health data. And I think everybody who works in the health data space or uses health data for research understands that there's been long-standing issues with our accessibility and the presence of data. Do we have the right data and so on? But this just really made that issue very clear to people who hadn't realized that it was in such a state. And so one of the results of this was that Public Health Agency of Canada decided that they needed to do something and establish this Pan-Canadian Health Data Strategy Expert Advisory Group. That was created in December of 2020, which if you think about the way that federal government works and standing something up, this was pretty quick, given the pandemic started in March of that year. We had our last formal meeting in August of 2022, and I will say that a number of us kept working together because we're really committed to making sure that recommendations that we made through this work don't just sit in a report and gather dust on a shelf or dust in the interwebs. I will also be very quick to say that what we did in this group was we provided advice on the development of the strategy. We certainly did not write a strategy for the federal government. That's not the way these things work. But I think that in the end, we did have some influence on the way that these things are talked about now. So I think that's I hope a positive. The membership of the expert advisory group included people from across the country and a really wide range of expertise, from clinicians and members of the public to people trained in law, and people like myself who are involved in research, people who work in the healthcare system. It really was a good mix of people who did not always agree or see issues the same way, but managed to come to a set of recommendations that we all really felt quite strongly about. The group was chaired by Dr. Vivek Goel, who is a public health physician, has had many different roles around health and health system, but is now the president of the University of Waterloo. So I'm not going to belabor this slide here, just wanted to make sure that they understand that what we put together were 3 different reports. One, the first being a sort of assessment of where we came from, why there's been these 60 years of having conversations about trying to improve health data, but not necessarily those translating into something that looked like real progress. So because we wanted to not do the same thing over again and hope that it would have a different effect, we wanted to try to figure out why those previous recommendations were not necessarily picked up, and then address that and try to do something different. The second report then is really talking about the health foundation or health data foundation that's in place already. And then the third report is really this idea of the recommendations that would take us toward a world-class health data system. I think all the reports none of them are terribly lengthy. They tried to get them written in a pretty conversational and easy to read style. So they're good for students, they're good for just background information, but the third report is the one I really want to talk about a little bit more. I mean, probably within this kind of audience, I don't need to say too much about the systemic barriers to sharing data. This pizza diagram, as I started calling it, really just says that we know that when people move through the health system or public health system, there's lots of data that are collected. And you go to see a primary care physician or primary care provider, nurse practitioner, whoever it is, there's data that's collected there. If you end up needing a laboratory or you're admitted to hospital, there's data that's collected there. Of course, there's all sorts of other health-related data that are accrued in either through population health services or social services. And as researchers, we collect data as well. And then there's these artificial barriers between these data sets. These all relate to people. They all could potentially, at least theoretically, be linked together to give us a much bigger and broader picture of people's experiences within systems and within receiving public services and other kinds of services. But that is not the case. These data don't always flow easily, even in the context of providing care to an individual within the healthcare system. They're not necessarily flowing as they should. And I will stress that these are, I'd say artificial, but there are real technical, policy, legal, and then what we're calling human interoperability challenges with getting data to move around. The result within the healthcare system is what patient and public partners describe as binder medicine. So what we've effectively done with the way we organize health data in the context of provision of care is made people responsible for curating and carrying around their own health information or the health information of a loved one. Now, this is particularly true for people who have more complex issues, but this is a story you hear all the time about how people carry their own information around because they can't trust that the system is going to have their information available when it's needed. If I take that more to the research side of things and secondary use, though I don't love that terminology, the other uses of data when we're talking about more aggregate or population level information, the access pathways that we have are often very circuitous, not clear where you need to go, not clear who needs to make decisions, how long it will take, and all the rest of it. Even worse, sometimes it's not clear at all that there is a pathway, and that the data that we want or that we need to do the kinds of analyses we think are important or going to help move either basic scientific understanding along or might apply to real world problems as they exist right now. It's just, there's not a clear way to go or understanding of what to do. And so these are some of the issues that fundamentally need to be addressed. And as colleagues remind me, that not addressing these issues is hard to pin down what the consequences are, but the consequences can be real harm to people. People have died because their health information doesn't move the way it should. And certainly we don't make as much research progress and scientific understanding as we could if we are putting artificial barriers up into the data access pathways. So if we think then about critical success factors and the foundation that we need for good health data, these 4 lines at the bottom are where we really came out on this, so that we need to have public trust in data literacy. And that's not just public data literacy, that's data literacy across all stakeholders within the health data space. We need effective and equitable data policies. We need clear and accountable data governance, and we need to have data interoperability and architecture, and that is both technical and, as I said before, human interoperability, meaning that we use the same words to mean the same thing, that there's mutual trust and all of the things that make working together and creating systems that work efficiently, that makes it all possible. Okay, so now I want to move on to the specific recommendations in the 3rd report. And those really revolve largely around what became the Health Data Charter. And this is something that we're still trying to move forward, because this is, well, I'll get more into what that's all about. The first recommendation in our 3rd report really is this kind of foundational North Star idea that we'd like everybody to endorse a vision that by 2030, everyone who lives in Canada will benefit from a fully integrated and a continuously optimized learning health system, and that the implementation will be guided by common principles in a Canadian Health Data Charter. Now, you might notice that I talked about a Health Data Charter. This says Canadian Health Data Charter. We actually modified the language on this, just call it a Health Data Charter now, because we realized after the publication of this report that the principles that we put in place really could apply anywhere and everywhere. It doesn't need to just be confined to Canada. And maybe it's better for us to think about these as universal principles and try to promote them that way. A little bit similar to for those who study these things, Ottawa Health Charter for Health Promotion and the Lalonde report, those things, those Canadian developed documents that have had a much wider reach than we might have imagined in the first place. The second recommendation is that all jurisdictions, and here I mean federal government and provincial and territorial governments, demonstrate support for First Nations, Inuit, and Métis Nation data sovereignty across geographies with a distinctions-based approach. So this is based on our signing on within Canada to the United Nations Declaration on the Rights of Indigenous People. And of course, we also have legislation in British Columbia that enshrines that as well. And so everything that we do needs to be aligned with rights holders in the First Nations, Inuit, and Métis communities. And then I'm going to now talk about the rest of the recommendations in the context of this Health Data Charter. So the idea of the Charter is that it puts people and populations at the core of everything we're doing around health data. And the reason we chose this kind of approach was trying to sort of mimic the 5 principles in the Canada Health Act, which not everybody can name off the top of their head, but I think they provide a really nice kind of grounding set of principles to think about what we're actually trying to achieve by having publicly funded healthcare services. And so the idea here is borrowing from that and trying to be as pithy as we can about the things that are fundamental to a really high functioning health data system. You probably push back on the pithiness statement once we go through these, but we really tried as hard as we could to do that. So there's 10 principles, and I'll just go through them reasonably quickly. So 1, And the first is that we need to make sure that health data are person-centered. I would argue that right now, health data are very much institution-centered, not oriented around people. So we need to make sure that we design systems where data will follow the individual for clinical analytic uses, whatever that is, that we really make people actually important to the way we think about health data. Second principle is that we have common standards for terminology, health data design, stewardship, interoperability, access, and portability. So there's just a whole range of standards that we need, and they relate to the way we think about data access governance, for example, who can have access to what data under what circumstance, how we make those decisions is stewardship. And so the fact that we have not even common ways of doing that within British Columbia, much less across the whole of the country, is problematic for anything that we might think of it in terms of efficient system design. The interoperability I've talked a bit about already. This is both technical and human interoperability, and then the access and portability. The third principle of the Health Data Charter is that we want to make sure, of course, that the quality, security, and privacy of health data is secured, and that we ensure that we reduce harm to individuals and populations. I just am quick to say that putting too much restriction on use of data can cause as much harm as putting too little restriction around the use of data. So we do need to get that balance right. The fourth principle is about timely accessibility, and this is to individuals for their own purpose. So we actually need to just fundamentally make data available to the people about whom the data represent, that they need to be available in a timely way for decision makers, for researchers, and for the health workforce. The fifth principle is that use of data for policies, programs, services, and statistics and research are for the public good. They have a public good component to it, and that we honor the importance of open science and what we're doing with all of these data, meaning that we share results, we share code, we share the learning we have from our use of data as a public resource. At the same time, we want to make sure that social and technological innovation through partnership, invention, discovery, and value creation are also valued. So this means that private sector does have a role in the use and production of health data. So, and I know that some might look at these two principles as being maybe antithetical, but I strongly believe that the way that we do this is by ensuring that anything that's done by the private sector that has private sector value also has some public good attached to it. And you can see from the international literature on public engagement that the public understands this. And we all want to have the benefit of new medications, new technologies in the healthcare system. We've been able to solve problems that seemed unsolvable with those kinds of innovation, but it does need to come with public good and public interest attached to any of those uses that we contemplate there. We want to make sure that there's health data literacy for the public, for the decision makers, health workforce, and you could go on and on with who needs health data literacy in this space. We need to think about harmonization of health data governance, evaluation, and policy, meaning that we're not necessarily going to have the same privacy legislation or the same data governance rules in every part of the country, but at least we can understand how they harmonize, how they work together, and where they don't work together well to try to find ways of addressing that. Again, the principle of Health Data Charter is the support for Indigenous data sovereignty. And then the 10th principle wraps around back to the first, where we want to make sure not only are health data person-centered in the first principle, but that we also include diverse members of the public, patients, and communities, as well as other stakeholders in health information system development and oversight. And I'll just underline here, I really think that we have to include the public in the rules that we set around how data are used, who can have access to what under what circumstance. These are values-based decisions, and that is a good indication that it's public input that we need. It's not just purely an expert-driven exercise. So if we think about pathways to implementing the Pan-Canadian Health Data Strategy, there was a task group put together back in 2020, sort of in parallel to the work that Expert Advisory Group was doing, some planning, to actually craft the actual health data strategy in 2021, development of a roadmap 2022, and then in February of 2023, you will have seen the budget that included not only additional funding to provinces and territories for development of services, but also for attention to health data foundations, but also in $505 million set aside over 5 years to go to CII, Canadian Institute for Health Information, CII, Canada Health Infoway, and other federal data partners to really try to advance the strategy. And that's where we are now. So there has been some progress. There's definitely been a real commitment, and there still seems to be quite a lot of enthusiasm for pushing all of this forward. In addition, this is, my personal perspective on this, but I really think that progress depends on all stakeholders, right holders, and interests working together. This is not something that and even the best and most well-meaning and most highly ambitious Ministry of Health is going to be able to do on their own. This really is going to take all of us rowing in the same direction and coming to agreement on how we want to achieve some of what I hope will be agreement on the principles in the Health Data Charter. We also need to think about building the future, but also work with what we have now, because there's significant issues in the health data space now. And I don't think that we want to look at this as a problem that we'll solve in 10 years or 15 years or 20 years. We need to start solving it today and continue solving it. And honestly, given the pace of change in the data space and technology space, I don't think this is something we'll be done with. This is something that's going to have to evolve. So if we set up the right partnerships and ways of working, we're going to get a lot further on that. I do see the Health Data Charter as key. If we think about common agendas, a common destination as a way to really bring different stakeholders together meaningfully, I do think that some kind of set of principles is a good way to do that. And I hope that I'll be able to say more about how people can get involved and show their support for the Charter, or offer their contributions to any changes in the Charter that need to be made. So it'll be a watch this space. I'll come back to that in the end. Okay, so now I'm going to move on and talk about Health Data Research Network Canada and some of our objectives and actions. So who we are, first of all, we are a network of member organizations from across the country that have a role either in providing access to data for researchers. It is mostly researchers at this point that I'm going to focus the rest of this presentation on, or they are involved in things that support uses of data. We have members in HDR in Canada, as I'll refer to it, across the country in every single province. 2 of the territories. We're working on developing relationships with Nunavut. It's just been really difficult for people in Nunavut to engage just because of the pandemic and everything related to that. And CII and Statistics Canada are also members of our network organization. So we are truly pan-Canadian, uniting all of the places like Pop Data that you'll hear more about in the next session, uniting these groups together to make it more possible to do multi-regional research. And so this is our vision and mission for Health Data Research Network Canada. Our vision is that data across Canada drive improvements in health and health equity. And we wrote our vision very specifically in a way that would immediately imply that we are not going to be able to do this on our own. We have to work in partnership with other groups, organizations, and people to be able to achieve what we really want to achieve. But our mission within that as a network is to bring together people and organizations across Canada for transformative and world-leading health data use, and specifically around supporting researchers who want to do multi-regional research. So you could use Pop Data and just do research in BC, or you can come to HDR in Canada and think about doing a 2 or 3 or 4 or truly fully pan-Canadian study using the resources that I'll now describe to you. What I'm going to do is I'm just going to kind of do a little Cook's tour of what we're doing based on, we have 5 strategic objectives. So I'm going to go through what each of our 5 strategic objectives are, and then show you some of the things that we're doing underneath that to make this vision a reality. So first of all, and probably most important for you thinking about data access processes from this perspective of multi-regional research, is to develop and improve services and supports for data access. I don't know if anybody on this call has actually tried to do multi-regional research, but if you can't go to CIALH or Statistics Canada and get the data you need, it's really, it was traditionally very, very hard to do this, because you would have to go and understand all of the data access processes in different places and understand what data they have and all of those things that just made, you know, doing a 3-province study 3 times as hard as doing a 1-province study. So it just didn't get done very often for very good reason. So we're trying to tackle those straight away in creating this data access support hub. So one of the things we've put together is a data asset inventory. So this is an inventory of all of the data sets that you can get access to through our collection of member organizations, and again, including CIALH and Statistics Canada. There are something more than 550 data sets that are in that data asset inventory, and something like 375 of those data sets are not available through CIALH or StatCan. So this is not just repeating something that already exists. We're really trying to delve into very much a new space. We also have an algorithms inventory. So there's about 175 algorithms in that. And these are a compilation based on a systematic review. It's this compilation of studies that have shown how we can define certain things in a multi-regional context. So it might be a definition for mental health or dementia, things like that, where somebody has actually done the hard work of validating a definition that might be a little bit different in BC or Manitoba or Ontario, but that actually gets you to the point of having apples to apples comparison when you actually use your data. So those resources are available. We've also done privacy legislation review across provinces and territories. And one of the ways that we put that and you can see that there's all of these things are available on our website, and we'll have a new website in just a couple of weeks, which I think will make things even easier to find and use. One of the ways that we put that review to work was to actually develop consent-based guidance for people who are wanting not even just to do multi-regional research, but actually to collect data in those multiple regions and then link those data. Then this is the consent guidance that will help you make sure that what you have in your consent form is going to be sufficient for compliance with all of the different provincial and territorial expectations around what it says and what people consent to. So those are some of the innovative resources that we have. We have also a very, I hope, clear process for how you might come to the Data Access Support Hub and make use of it. You can register for the DASH system on our website, submit an intake form, just a few questions about what you're interested in, what you're looking for. We organize a meeting, and I believe our service expectation on this is that you'll hear back from us within 48 hours or so and have that meeting within a week or so. So this is we try to make this as quick as possible. And some of the things that we can provide within, after that meeting within the first 2 to 4 weeks are things like a feasibility assessment. Can you do what you want to do with the data that are available? We can provide you with a cost estimate, and we can provide you with a letter of support if you're submitting to SSHRC or CIHR or some other funding agency. We can provide you to assurance in a letter that says, yes, this is consistent with what we're able to do, and here's how much it's going to cost. And now I'm going to be quick to say, HDR Canada does not charge anything for the services that we're providing. We're funded by CIHR to build this Canadian data platform. But we do have charges that come from our member organizations. And so that's what we're talking about when we're talking about the cost estimate. And there's nothing on top of that from HDR Canada. I'm not going to try to go through this whole slide, but it's the DASH process overview, and it will give you a sense of where we are now with making this work. And then the thing I really want to emphasize here is we've gotten as far just in the last few months to be able to say that now if you come to DASH, we can do all the things I just described, but we can also give you one form to fill out for your data access request. So instead of going to 3 or 4 different places and filling out 3 or 4 different forms and then managing that process all the way through yourself, what we've done is taken that away from your responsibility as a researcher. There's one form to fill out that we then populate into the individual provincial and territorial data access request forms. And manage those processes on the back end. So it will not, it still will take some, we can only control so much of how long it takes from request to delivery of data. We're working as hard as we can to minimize those as much as we can, but some of that is absolutely out of our control as data centers at this point in time. But we can remove the burden and the financial, including both the human and the financial burden on your research team by taking much of this away from what you're required to do beyond constructing what you need and putting that into this common data access request form. So I think this is a big step, and then there's more coming that I hope will make things even better. I'm going to go pretty quickly now through these other things because I do want to make sure that there's time for discussion. So second objective is to diversify and harmonize data and support innovative and privacy sensitive data use. So one of the things that we're working on here is actually looking at the feasibility of us developing some common data models. This could be C nodes, and it could be OMOP, which is a pretty I don't know if it's comprehensive, but it's a well-used, internationally accepted common data model. And the idea here is not to tie ourselves that we can only produce one common data model, but to see if we can't learn from these to develop these resources. Because if you think about the ability to do multi-regional research, it requires harmonized data. One way to harmonize data is to use the algorithm inventory that I described. Another is, if it's possible for your research project, to use pick and choose variables that have already been harmonized in a consistent way across the country. So that's the purpose of this common data model feasibility project, which we think will cut a lot of that data wrangling that's necessary for administrative data right out, with assurance that what lies behind all of that work has a high quality and consistency across the country. Another thing that, of course, we've heard lots of requests from researchers is they would like to pool data. We can't promise that that is possible to do. There are actual legislative barriers to being able to move data out of provinces and into a common location for analysis. At the same time, there's also lots of scientific development that would suggest that for many kinds of analyses that we might want to do, the data don't need to be in the same place in order to do really high quality, robust analyses. And so what we're planning right now is a webinar series that will be a learning series on the state of the science of federated analysis, really just to make sure that we all have a common understanding of where things are in this area of scientific development, where there's more development that needs to happen. And with that, then understanding what permissions and structures would we need to have in place to really support federated analysis. So this learning series is, and it's going to be learning for all of us who are planning this as well, to be clear. I don't think that there's any of us that think we have a handle on all of these things, but this is going to start in the new year and will run probably monthly for 5 or 6 months. So that's something else to watch for. This is coming. We want to use data to strengthen and improve equity. And of course, we want to do everything with the idea of supporting Indigenous-led data sovereignty. So it's not for me to design what Indigenous data sovereignty looks like, but we want to be an organization that supports the precepts and desires of Indigenous communities and peoples. And so we're guided by things like the OCAP principles, the CARE principles, which were developed by the Global Indigenous Data Alliance, and of course, other basic things in the use of health data, like the FAIR principles for data being findable, accessible, interoperable, and reusable. And again, I hasten to say this does not mean that data need to live on the internet someplace. Findable just means that we make things transparent and it's very clear what you need to do to be able to access the data we're talking about, because they are, of course, sensitive and are guarded appropriately and consequently. In terms of the principles of equity, and here we're working with inclusion, diversity, equity, and accessibility, or IDEA. One of the things that we really need to make sure that in our the training we provide to students and people who are using data, that includes an understanding of where there may be bias in the data. And I think we've talked a lot about bias in data, and often, at least in my training, we talked about how to design bias out of the data. But I think one of the things we're coming to understand better is that bias in data can also represent bias in systems. And so sometimes we don't actually want to design that bias out. It is something that it's a feature, not a bug, and we need to understand it. If we're going to actually improve systems, we need to understand where people are having trouble reaching the systems that or the services that they need, where they're being treated differently for whatever reason that might be. So this I think is a really interesting, active, and incredibly important area of research that needs a lot more people with attention to it. We are working on establishing and strengthening partnerships and providing leadership for evolving data practices. This really relates to that idea that our vision is bigger than our individual organizational mission at HDR in Canada. And so one of the things we're doing is actually helping our colleagues across the country develop new data centers where there haven't been data resources available for researchers in the past. The HRDP, the Health Research Data Platform in Saskatchewan, is now open. They have not, this has been a really, really big change in Saskatchewan, and the University of PEI is very close to opening CIDR, which is the Secure Island Data Repository. I don't want to claim that we were the only ones who were working on this, but we did provide support. And of course, some of that was financial, but some of it was also just the learning from across the country, so that these data centers were able not to just have to start from scratch, but to build on everything that was available to them from other data centers in Canada. So these I think are huge, important advancements. And we're now working with the Yukon Spore Support Unit on thinking about Yukon, and we're developing relationships with the Council of Yukon, never get this right, CYFN, the Council of Yukon First Nations, as well, because of course Yukon is interesting because they are unceded territory, so there's already a different relationship there. We've also, you're going to hear more about CLSA, Canadian Longitudinal Study on Aging, and CanPath, and specifically the BC Generations data later. They're wonderful, wonderful data sets, and really important to understand how to access those individually. We now have agreements with both of these cohorts for linkage into the broader system data that we can make available through our collaborative data centers across the country. So that's just another way that these data can be used. By no means, there still will be obviously a pathway directly, just if you want those data on their own. You'll hear more about that later. But the linkage piece is the one that we're trying to shepherd and make more possible. And these have been really, really productive partnerships, and I hope that people will be excited about the possibilities of using these linked data. We're also venturing into the area of training for pragmatic trials, with pragmatic trials really just representing trials that would use routinely collected data, either for primary outcomes or the ability to follow people over the longer term. It's much, much less expensive to do a 5 or 10 year follow-up study using routinely collected data than it would be to maintain your cohort and then do that individual follow-up with people much later. So this, again, you can watch for an announcement about this, but the training program is meant for people who are going to lead trials, but also for people who would be highly qualified personnel that could support trial design, trial implementation, and that sort of thing. So I think this is going to be a really interesting development. The last objective that we have is for ensuring ongoing public and community involvement. So this is our Public Advisory Council. We have, I think this is we're just updating the council now, saying there's now 14 members from across the country. Frank Gavin is at the top there in the slightly larger picture. He's been our chair of the Public Advisory Council. He has 25 years of experience, at least, with multiple organizations and working in the patient advocacy and public informant space. Our Public Advisory Council advises on priorities for projects. For example, we've completed a social license project, like what does the public actually want to see in the use of health data. They have a communications interest group to make sure that what we're doing is transparent and understandable to the public. They meet about 5 times a year. One of those meetings is in person. So this is a really important group for us. It's a really diverse perspectives. We operate this council bilingual. So we do have native French speakers as well as bilingual and then English speaking people on this council. The social license for uses of health data, this report on public perspectives, this is available online. I just wanted to highlight a couple things, and really just this idea that for sure there was absolute consensus agreement within the group that we worked with to say that the health data should be used for clinical care, for health systems improvement, and for health research. People don't, they want the appropriate guardrails, but it is absolutely, those are things that should be used for. There was less agreement, for sure, not full consensus, about the use of data where the purpose is either to sell or otherwise use data that doesn't have a public benefit. So that public benefit piece is really, really important. And of course, it's really hard to define public benefit. So that's a challenge. It's part of the reason I think that we need ongoing input from the public on all of this. And there was not consensus as well on private companies or about data about systemically marginalized populations. So the idea there being that if data have been used in the past to marginalize or oppress people, then we're not going to be, they're not going to be very quick to say, yeah, sure, go ahead and use our data. This is where we actually need to change the way we're doing things to be consistent with public expectations. I just wanted to highlight that in April of this year, we had our first public forum. It was called Health Data for All of Us. And this is Rachel Plachinsky was the keynote speaker. These recordings of the sessions from that day are available on our YouTube channel. So that's there. And this just underlines our commitment to involving the public and really making all of this a little bit more accessible to members of the public who are interested, but not in working in a professional capacity in the health data space. And so last slide here is what's next. We're going to be working, as I said, on more collective efforts to support the Health Data Charter. We do want you to provide your input. We'd love to hear from anybody about ideas or concerns or things you wish would be different. We are going to be having a series of webinars. We do a couple times a year now have a regular DASH webinar to give people an idea about what services we can provide. Those are usually timed a few months in advance of CIHR deadlines. The federated analysis, and we have an idea learning series. Both of those you can watch for those. The recruitment for the pragmatic trials, and we have a newsletter. So there's ways to subscribe to make sure you get information about what's coming next in all of this. And with all of that, I'm going to say thank you and take the slides down and hope that there's some questions.